I'm going to try to quickly go through some interesting things that are largely behind us, thankfully, but still are issues in the world and are things that are interesting to us with our sort of global perspective to understand, because we don't see these things in the United States typically. So I'm going to focus on onchocerciasis, vitamin A deficiency, and trachoma. All of these have some systemic involvement, and so it's important for people in general health to know about them, and all of them have had highly successful control programs, some of which are somewhat ongoing, especially for trachoma. So onchocerciasis is a very interesting condition. It was my favorite one when I was getting interested in ophthalmology because of something that could really be addressed amazingly by public health. It's caused by a worm, and it's transmitted by a black fly called Similium damnosum. So easy to remember the name if you can just... So it's endemic in sub-Saharan tropical Africa mostly, and a little bit in Latin America, and it sort of was extremely economically destructive by sort of denying farmland use in much of West Africa, sort of causing famine and so on. And it's sort of a very interesting instance of a tropical disease with sort of very effective, very popular with the patients, cost-effective, large-scale treatment, which is included in insecticide treatment and now relying on ivermectin. And so this is the perpetrator here, and here it is in tissue, and you get hundreds of thousands or millions of these after having this little syringe injected into your system parenterally, and it spreads and can be a problem ongoing. It's been endemic in 34 countries, mostly in Africa, and 99% has been in Africa. And it's also complicated because conditions are difficult in Africa, and so people are constantly mixing and moving around, and so things can get spread all over the place, like we're worried about with Ebola. I don't know if Steve is going to talk about that later, but we're having an issue with it currently. And it's had enormous improvement with programs, so we'll talk about that. Here's an old map sort of showing the distribution. There's not much of it in Ethiopia. In Ethiopia, the ones that have it have not typically had much eye disease, but it's been mostly in Western Africa and sort of in the Congo Basin. And it's sort of been difficult to get rid of it here because of wars. And a little bit in Latin America, but not very much, and declining. So it's almost exclusively a parasite of man, and no reservoir is known. And people develop these live worms that are called macrofilaria, and they live in like a fibrous nodule. And usually the nodule is kind of hidden, but it can sort of, like people can have this nodule often on the head because they often get bitten in that area, typically over bony prominences. And each of these will contain 2 to 3 sort of giant worms that are sort of like a gigantic, microfilaria manufacturing system that create vast numbers of microfilaria, which are the ones that cause the problem. So here is what it might look like with the worm, the macrofilaria all wrapped up into a nodule like this. And they can live for 10 years to 15 years and produce 1,600 microfilaria per day, as long as there's a male there. And so they can people can almost have like, a 250 million microfilaria in their body. And then these migrate to the sort of superficial tissues, including in the eye, and they can live there for months, and then the Similium fly can come back and gobble them up and resume the life cycle. A small proportion then will migrate to the thoracic muscles of the fly and develop into the infective stage, and then they can be re-injected into another person. So this is sort of your typical parasite life cycle diagram. And so the ocular disease is caused by the microfilaria, not the macrofilaria. And you can see them in the eye. They might be moving in the cornea, and especially in the anterior chamber. If you have people lay over like that for a period of time, they'll kind of come out of the angle, and you can see them like swimming around. And they can also cause fluffy, like inflammatory deposits in the cornea. And this can lead to sclerosing keratitis, which is one of the major pathways to blindness, as well as chorioretinitis and optic nerve inflammation. And so the microfilaria can get into all the tissues of the eye except for the lens, and can also cause anterior uveitis, leading to glaucoma, or we should more precisely say pressure problems that then lead to glaucoma, and cataract, and then optic neuritis and optic nerve atrophy, not in the demyelinating sense, but in the inflammatory sense. And chorioretinal lesions can result in blindness as well. So these fluffy deposits in the cornea, could be other things. There's a differential for this, but you can get this and it can expand to be more extensive. This could be confused with trachoma and other things as well. But if you're in a highly endemic area, there will be scads of people affected. And so, your sort of pretest probability for onchocerciasis will go up. And if you see worms swimming around in the anterior chamber, then you probably have the diagnosis. And then you can end up with like a completely opaque cornea. And you can also get chorioretinitis. It typically looks more like scars. I haven't personally seen much of it, but I'm not sure if I've ever seen a clear-cut case. And then, they can get optic atrophy. And so you can have all different parts of the eye affected, but mostly the cornea and the optic nerve and the chorioretinal lesions are the main things, as well as the microfilaria swimming around. It tends to be more anterior, posterior in different parts of the world as well, so it must be some difference with species. Now, they also get a systemic manifestation, and so since this tends to be in the subcutaneous tissues, they have it in the skin, and they have this leopard skin, it's called, that looks really awful. And this is sort of the salvation of the patient when you have the treatment, because this just feels so itchy and awful that people will go to great lengths to do anything to interrupt that, which makes them want to participate in the treatment program, where you can give ivermectin, once a year, and then after a year, they may start getting itchy again. And I think there was even like a street value for the drug, and so it's sort of an ideal public health program where everyone's dying to get the medicine. And so, but they can get this pretty nasty looking skin situation. And this can affect like up to 10% of people in the areas that are affected, although mostly it's much better now because the control programs have been successful. So it tends to occur in rural places rather than urban places. And it's on the range of these flies that this depends. And they breed in rapidly moving rivers. And so this is why this is called river blindness. And the whole community will be at risk, especially if they're close to a river. And the men tend to be affected more because they're sort of out doing things away from home and more exposed to the flies. And so, like I said, this had a big economic impact, so just sort of a river. I should acknowledge I got these slides, which I modified from the Dana Center for Preventive Ophthalmology, so I think Hugh Taylor might have been the original person who did this. So the Similium fly can go a long way in a short time, usually blown by wind or following rivers, and so it's very easy for it to reinvade an area that's been cleared. And so you kind of need continuous maintenance of population treatments. And if there's a lower population density, then people are more likely to get bitten because the flies want food. And so in a way, it's worse if there's a low population. And the dense populations may sort of damage, cause pollution and so on. And this usually is bad, but can eliminate flies potentially. And occupation will increase exposure if you're out and about. Some of the protective strategies can be to locate the village further from the river and dig deep wells so they don't have to go wash in the river and so on. And potentially a large proportion of people could end up blind in the past and life expectancy be reduced. There's actually a probability that being blind just reduces your life expectancy in general. I'm hoping to look into that in the next few years. And then people may leave, because things aren't going well. I mean, this is a big issue everywhere with urbanization, but this may be one of the contributing factors. So cutting out that big node, you would think would be the thing to do to interrupt the production of the new microfilaria, but that doesn't seem to work because usually there's other nodes that you don't see. And so it doesn't have a big role. The main programs have been the onchocerciasis control program, which relied on spraying insecticides to clear out the Similium flies, and then the ivermectin distribution programs. So you had to kind of spray this huge area, and actually the World Bank was the one that kind of made this happen because it was causing economic devastation. And so you need to have, not a forever insecticide to spray, but with this, it worked really well to sort of spray in this area, and this was an extremely successful program. And so they would apply by helicopter around and sort of have this, flight control that they would kind of cover the whole area. So it was a very top-down program, but was very effective. And so supposedly 100,000 people were saved from going blind from this, and it opened up 250,000 acres for food and to avoid people having to move somewhere else. So this was amazing, and it cost something like $1 per person per year for the program. With ivermectin being recognized as having this amazing effect, then they kind of phased this out and moved to ivermectin programs. And so ivermectin is a drug that's really nice. If you treat worms, you can potentially get this sort of Mazzotti reaction, which we have this with many things like with syphilis and tuberculosis and with like immune recovery uveitis and other immune recovery inflammatory syndromes in AIDS patients where you sort of suddenly expose the body to a lot of antigen and you get this massive inflammatory response. And so the ivermectin basically stops it sort of prevents the babies from being born, the microfilaria, and so instead of doing that, it just kind of clears out the flow of new ones, and so it's a much safer approach. And so they have done programs with this that will kill, or I shouldn't say it kills microfilaria, it prevents them from being born. And it alleviates the itching and reduces the number of microfilaria drastically. And so it's been an amazing program. And Merck & Company has offered ivermectin, I think, over 1 billion doses now, free for this program. And I've always thought this was an intriguing thing because, like, if Merck is making money, they can tax deduct the full retail cost of this, and the tax deduction probably is worth more than the cost of producing it. So it's actually like a win-win, potentially. So I'm hoping that, like, other companies can get that kind of perspective. But that's been an amazing thing. And macrophilaricides still can't be treated, but it seems like this is largely helping the issue. All right, moving on to vitamin A deficiency. This was something very interesting. So vitamin A was fairly recently described, and systemic associations of vitamin A deficiency were sort of very prominent in the world and very well known, but as prosperity came to the West and gradually coming to other places, it was kind of forgotten about. And so one of my PhD committee members, Alfred Summer, got interested in this, vitamin A deficiency with keratomalacia and started doing research about it and did this big clinical trial. And he tells us, he's a colorful character, and so he tells this story. So he's Jewish, so he has Christmas off, but he's finished with the holidays early. So he was planning to analyze all of the data from his study. And then he's like, oh no, the two treatment groups have like drastically different mortality, and it's going to like invalidate all of the results, And then he's like, I wonder why there would be like a 30% difference in mortality between randomized treatment arms, And it turns out that vitamin A deficiency is highly lethal to extremely nutritionally deficient children, and so it ended up being kind of one of the amazing advances in alleviating child mortality, although it took like 8 trials before anyone would believe it. And so this was eventually understood as a major cause of childhood blindness, or death, kind of overwhelmed the blindness attribute. It works for blindness prevention too. And so this has sort of been scaled often along with immunization programs. So vitamin A refers to sort of the class of drugs or class of molecules related to this like retinoic acid. We know it's very important for phototransduction, like with the photoreceptors. And people can get sort of night blindness because of that if they're vitamin A deficient, especially adults, like pregnant women is commonly seen, because getting pregnant is an acute drain on vitamin A. And measles is the other thing that often precipitates a disaster in vitamin A deficient children. And so, one of the ways you can approach it is to increase it in diet, which can be challenging with traditional diets and so on. It's like most problems, mostly affecting the poorer parts of the world. It used to be really big in India, which, with economic development is getting better, and has been an issue in Africa. And also, things are getting better in Africa, so it's becoming less of a problem, but still an issue, as Jeff was mentioning in his talk. There's a whole sort of descriptor or set of descriptors about it. The World Health Organization tends to get interested in these kinds of things and sort of develop like a common way of discussing them. So we talk about xerophthalmia with this. So it's not actually that their eye is dry, but it looks dry, and the surface is sort of poorly wettable, because of the damage to the surface from having a lack of vitamin A. And so the different signs are night blindness, the sort of xerosis on the conjunctiva or the cornea, and then what are called Bateau's spots, which are actually caused by colonization by a bacterium, but it tends to happen with vitamin A deficiency. So this is sort of the xerosis. You can see it looks rough. It needs to have molecules on the surface to make it wettable. And here's the Bateau's spot. It could happen with other things, but it's highly suggestive of vitamin A deficiency. You see it sometimes in the US with chronic alcoholics and people that have like bowel surgery where they can't absorb vitamin A. And then corneal xerosis is supposed to be a worse stage, and then corneal melting, which might occur when you sort of have acute vitamin A deficiency with measles frequently. So measles vaccination is kind of an important aspect of avoiding blindness from this, measles being like almost the world's most contagious infectious agent. And the corneal scarring can happen after this happens. I remember when I first went to Ethiopia, or after I moved to Ethiopia in 2016, we did an outreach in Amhara, and there were all these people that must have had this, when they were young, that had just a white spot on their cornea, and allegedly were no light perception, but were more like light perception, I think, in their vision. And then you can get fundus changes as well. So here's the corneal xerosis. So it's not a good look for a cornea. And then they can melt and perforate. And so that's the main cause of blindness from this condition. And then they might end up with a big scar later on. And so especially people that are like probably 30 plus, you'll see this sometimes in Africa, but it's not completely abolished, unfortunately. This was all well described in the past, and was described in Scandinavia and could be cured with butter. It was thought at that time, and it sort of disappeared with prosperity, like I said before. And so there were a whole big series of randomized trials, and when I was a public health student at Hopkins and young faculty, everyone was working on this. They were looking at it in so many ways because it was just sort of a new thing. And so Summer actually got the Lasker Award eventually for that. And you can give this high dose once a year even, or once to twice a year is what was done in these trials, and it largely abolishes the problem. And so it's been amazing. It's the idea of sort of supplementing with vitamin A has been tried, but it makes everything yellow, and people don't like yellow sugar and things like this. So that's not really caught on, or yellow rice or something like that. This is, if you give a high dose like this, it can be fetotoxic, and so this is another issue. And so there have been trials about vitamin A deficient pregnant women, and they were able to treat safely with sort of low doses given very frequently, but it's sort of a perilous situation. But for children, this can be easily done. All right, so moving on to trachoma. So this was this is still said to be the leading cause of infectious blindness in the world. I think maybe that's about to pass because there's a lot of progress being made, but it was formerly thought to be the second or third leading cause of blindness in the world. I think that was exaggerated. I think cataract, refractive errors, glaucoma, probably have been the main ones. But this has been a big problem, and it's, preventable. And so that's very, interesting. It's the leading cause of infectious blindness, and that's partly because it's often typically bilateral, and corneal damage at the end stage is largely irreversible. But if you can interrupt before then, you can avoid blindness. So avoiding things like with glaucoma, for instance, is always one of the difficulties, because people are not necessarily motivated to be treated at an early stage. And many of the famous ophthalmology centers in the world, trachoma was part of what led to their being founded, or one of their main focuses. There have been, about a quarter of the world's countries affected. And Ethiopia, one of the reasons I was interested in Ethiopia, among many, was because of this disease, because there's just so much of it there, and like half of the world's burden is in Ethiopia. And originally there were like 250 million people in endemic districts, and so it's getting better now. And over 2 million visually impaired and over 1 million irreversibly blind. And there was a huge global mapping project, sort of like a census of trachoma done worldwide to sort of plan for doing alleviation programs in 2004 led by an infectious disease specialist named Anthony Solomon, or Saul, he goes by, who's now like the neglected tropical disease leader for WHO. And this led to a huge sort of charity investment, because this is sort of a very compelling disease. You have especially like young mothers and ladies that have this eyelashes like scratching on the corneal surface, and all of you have treated corneal abrasions, and you know how miserable the patients are. And so if you can just imagine being like that for years, it's just awful. And so there's been a lot of investment in trying to alleviate this, and it's made some progress. So there's data suggesting that this existed even 27 centuries BC. And you can find epilation forceps in Egyptian tombs. It seems like, Egypt and the Horn of Africa are sort of where it must have come from. And it was described by Hippocrates. And then after like wars where Europeans were invading Egypt, they kind of brought it back to Europe. And then if you go to Ellis Island in New York, that was like the biggest reason why people were turned away when they had, come across the Atlantic in steerage, and they get there and then they flip their eyelid and they have scarring and they're like, back to Europe for you. And probably all those people weren't infected anymore at that stage. It's caused by a gram-negative obligate intracellular pathogen chlamydia trachomatis. And chlamydia trachomatis is mostly famous in the West as a sexually transmitted disease. It's a different strain that causes the ocular one, but actually the limbus is a lot like the cervix. And so there's a lot of similarity in the mucosae there. And there's no known animal reservoir, and it's, has, as you know, the characteristics both of a virus and a bacteria, because it's like an incomplete cell and has to replicate sort of like a virus in a cell. So it infects sort of in the way that you're familiar with. It mostly affects mucosae. And anyway, there's some basic science to it. Antigenic variation allows it that you never get effective immunity that will clear it, but so the immunity is mostly causing trouble, really, scarring and so on. And the pool of active infectious diseases in children, and it takes the form of a chronic follicular conjunctivitis, mostly affecting the upper lid, the upper palpebral conjunctiva, and also gets follicles there, and then you can get little spots called Herbert's pits for sort of like where there was a focus of scarring around the limbus. And it can lead to scarring of the conjunctiva, obscuring the vessels. And then the party line is that multiple infections slowly cause more and more scarring, and it leads to contracture that rotates the eyelid in. So the eyelid turns in, you get lashes on the cornea, it erodes the cornea, then you get superinfection, and that leads to blindness. So here's a normal palpebral conjunctiva, and then here's one with sort of intense inflammation where you can hardly see these vessels anymore. And so that's a sign. And there's a lot of mucus being done. And often they have mucus like pouring out of their nose as well. Like you see children that have mucus here, and they're covered with flies. And so that's trachoma. And can you advance the slide? There we go. And this is showing the follicular. So if in like this area here, you have more than 5 of these, then it's considered to be TF, follicular trachoma. Can you advance the slide? And then here's the trachomatous scarring, a bad case. And so if these are contracting along this axis, it's going to rotate the eyelid in. Next slide. And then you get the lashes then put into contact. You also get like the mucosal surface, it transitions from mucosal to squamous at the eyelid margin. And so it sort of changes it to mucosal epithelium as you get entropion. And so then this as well, it's also causing damage to the cells secreting mucus to make the surface wettable. And so, the surface is already a deficient surface and having like a ocular surface, disease kind of pattern. Probably we can learn a lot about managing ocular surface problems from studying this disease. So this is called TT. So TT and TF are the most famous things. Next slide. So here you can see a diagram. So here this gets scarred and contracts, and so then this leads to the lid rotation and the application of the lids to the cornea. Next slide. Next slide. So affected communities tend to have poverty, so it's a disease of poverty. Like poverty is like the cause of this disease. And they had a lot of it in Saudi Arabia, apparently, and nothing in particular was done other than oil being discovered. And just the prosperity that came from that just kind of made it go away. So I like to say the best public health treatment for trachoma is wealth. So if we can just make everyone wealthy, it will go away. But in the meantime, we can do some other things. So next slide. This is the latest, or fairly recent distribution. Now we have very detailed thing from this tropical health organization that Saul founded, and they have detailed information online about the burden of this. And so Ethiopia has the biggest burden. It's also big in South Sudan and in sort of the north of DRC, and then in Tanzania and other foci of so on. And so Ethiopia is the big place. Next slide. So the active disease is mostly in very small children. There aren't gender differences, and scarring and trichiasis tend to happen more in women. So I'm a uveitis specialist, and so I always think, well, women get more inflammatory disease in general too, so maybe it's partly that. But it's thought that it's sort of more exposure to children cumulatively that leads to this being more in women, although I think there could be an inflammatory aspect to it too, because not everybody gets TT, only a small percentage. Next slide. So lack of available water is one of the major factors. So providing water so that children will can wash their faces and don't have to walk like 2 miles every time that you see these people walking with big buckets or big sort of yellow containers that are originally for transporting oil. And so making water available is a big issue. And then encouraging them to wash faces, which is a difficult thing to do if the water is really scarce. Next slide. So studies their randomized trial actually showed that TF drops significantly if you did formal face washing other than just sort of general hygienic recommendations. And so this became one of the linchpins of treating this at a public health level. Next slide. And flies actually are a big factor. So my colleague Wandu Alamayu, who's sort of a prominent motivator about trachoma, he says, the flies have teeth. They have teeth. Like if you go to Ethiopia and you have flies land on you, you can't just go like this. Like you have to, smack them and they'll be crushed on your face before they'll move. And so probably the particular strain of flies is a big issue because you have parts of the world that have trachoma and parts that don't that seem to be exactly the same. But, so the flies are probably the reason for that. And this has been formally shown by Matthew Burton and colleagues in a recent program that's just being published called Stronger Safe. SAFE is sort of the acronym about the alleviation program. Next slide. And next slide. Next slide. So historically, this is treated with tetracycline ointment. So you can imagine giving it several times a day for 6 weeks was challenging, for people that had never seen a doctor before. And so one of the big breakthroughs was that a single dose of azithromycin, so this single dose theme, onchocerciasis, vitamin A, azithromycin, all these things seemed like they could be addressed with a single dose. And again, Pfizer took on to distribute this, 1 billion doses of this, which was a fairly expensive medication at the time. And so the idea that they try to do is to treat everyone, I think over 6 months of age. It's contraindicated in pregnancy, but mostly because of effects on the fetus, not like major malformations, but treat almost everyone and try to clear it out of the community. Next slide. And then really the main thing that we do in ophthalmology is lid surgery. So like everything else is a public health issue. And so many techniques exist, and I'll try to talk some about those. Next slide. So this is the bilamellar tarsal rotation technique, which is the traditional technique for doing this. So you make a full thickness incision through the eyelid, and then you try to kind of imbricate this inward so that the distal part turns outward like this, and then tie it so the tension rotates it like that. So a full thickness incision and then rotating it there. Next slide. The posterior lamellar or trabou technique only makes an incision on the inner side, so you flip the lid out and you cut it here, and you do something similar to attach it to the anterior lamella here, but they kind of tuck the tarsus into the little gap here, and I think for this reason this technique works better, as we'll see. Next slide. And people have tried to develop a vaccine for this, but it hasn't really worked. Even people seem to be tending to be worse, so maybe suggesting that the inflammatory aspect and the sort of, changing the antigens like worms do are factors with this. Next slide. So the programs then address these. Next slide. All these different things. So this is the official thing: surgery, antibiotics, face washing, and environmental changes. So it should really be EFOS. This is logically the first thing, and then this, and then this, and then this. And partnering with the so-called WASH, like water and sanitation sector, is very important with this, and then antibiotic distribution programs and training. Next slide. And so anyway, we've been doing some research about this in Ethiopia. So one of the things was doing like a training program. So the surgeons that do this are all nurses. It's like the one thing that ophthalmologists don't want to do, because it's all in the rural places far away from the schools and so on. And so everyone's agreed nurses are going to do this surgery because it's not very difficult. And so we looked at, with CBM, it was sort of CBM pushing towards doing this to see if refresher training, like practicing on a mannequin and then having supervision by experts like my partner, Dr. Demisay. And this actually showed that with experienced surgeons, there was like more than a 20% reduction in postoperative TT or recurrence of trachomatous trichiasis after surgery. So even with people that have been doing hundreds or thousands of surgeries, this improved things significantly with about 100 patients in each group. So not even a huge sample size. Next slide. We also, as part of the FLAME trial that we did, I probably should have put the FLAME trial first, but we compared the two methods, the bilamellar and the posterior lamellar or trabou, and something like 70% better outcome with the trabou. And so that was a surprise, I think, to everyone. But this was actually confirming a result from a formal, straight-on randomized controlled trial that showed the same, but people wouldn't believe it. So I think it's sort of put to rest now. Next slide. And so it was having a big difference. The side effects are about the same. The BLTR also kind of looks a lot messier in the early stage. And so I think the PLTR is sort of going to be the popular one going ahead. And WHO has said, actually they said it before our paper, that we should train the new people in that. Although another trial by Emily Gower and colleagues found that the people who are very experienced in BLTR still did at least as well with that, so we don't think they have to like change. Next slide. And then we did this big thing, so as an inflammation specialist, like, steroids should help. And the trials that have been done, they haven't found infection really in the people with TT. So we did a preliminary like phase 2 trial of this and had really good results with like a 1/3 reduction at a year in all 3 groups compared to placebo and contralateral eyes that weren't operated. So we did this huge clinical trial and basically proved that it was a false positive, unfortunately. So next slide. So we didn't see any effect. Like the hazard ratio was 1.00, and but anyway, one of the observations though is that like 99.7% of people in the program, which was just sort of a normal field program, said they were satisfied or highly satisfied. Over 90% said highly satisfied, and actually like 13% had postoperative TT. So some of the people with postoperative TT were saying they're highly satisfied, which I think is because a lot of them only have 1 or 2 lashes touching. Next slide. I think that's the end. So anyway, trachoma is kind of an exciting area that's still pretty active, but it's kind of winding down. And so praise God, these amazing public health strategies were found and were applied widely with the help of charities. And there's something to be said for a bottom-up program that develops and then sustains itself, like the program that we developed at our eye center. And you've heard others talked about at this meeting. But for selected things, a top-down program can really end things. And this was a lot of why I was attracted to ophthalmology, knowing about these things. Thank you.
Okay, thank you. Okay, do we have some questions for Dr. Kempen?
John, it's always a great talk.
Thank you.
Got to spend a number of months in the Belgian Congo and actually got to see onchocerciasis, spending was at an area called Chikaji. And I'll never forget some of the little pearls that the ophthalmologist said, because I was just a medical student at this time. He said, make sure you have, and I went on to corneal disease, helped inspire that, but he said, make sure they bend over, have the head between the knees for at least 2 minutes.
Yeah.
Make sure the room's really dark, get a very thin beam, and then you can visualize the microfilariae. And in those areas, you just do these skin snips with shaves. Just shaving, you can see the microfilariae, emerging microfilariae in saline. So that was kind of a really neat thing. Didn't need fancy diagnostic stuff. So for those of you that are traveling to endemic areas, you can do antibody testing. But the problem is it doesn't differentiate between past and old disease.
Yeah.
With that, and the other thing I was just going to add, and you may have mentioned it, maybe I missed it, I wasn't listening as good as I should, is that supplemental doxycycline, in addition to the ivermectin, I think it's 100 milligrams for 6 weeks, we have to double check that, really greatly helps in the suppression of the microfilariae. So adding that to the ivermectin, but you had to do it about 6 weeks. So,
yeah, there's like a commensal bacteria that enhances the virulence.
The endosymbiotic effect is what's happening because the other bacteria that causes the big toxicity with it. Yeah, so it's a great talk. Thank you very much.
I think I talked too long anyway, so I had to cut some things. But
that was good stuff, though. Good
Hi,
stuff.
John.
Any other quick final question?
Hi, John.
Yeah.
One here. Say, John, can you relate of any experiences of missionaries contracting onchocerciasis?
Yeah, I haven't heard too much about that. I think, people who are missionaries usually don't kind of expose themselves to, the very worst conditions. And so I think people tend to be protected and tend to not live out in the bush. But there are some people who must have acquired it, because there have been people that have done that. There's some famous missionary stories, like Bruchko is one that comes to mind, where they just kind of radically went out into the community, and like he had all these stories about waking up with worms coming out of his mouth and stuff like this. And but if you take azithromycin ever, it would largely help to avoid it. But I guess if you get the established macrofilariae, maybe you might have an ongoing problem. But if you just take the azithromycin like once a year, it largely keeps it under control. Or ivermectin, sorry. I'm mixing the two. Yeah.
Thank you for your service in Ethiopia. It's very inspiring. I wanted to ask about ivermectin quality issues and potential toxicities, because I understand Americans were using ivermectin for COVID and maybe even stockpiling it? Thanks.
Yeah, so it's donated by the company and distributed by the International Trachoma Initiative. And there are shortages that come from time to time, but it's like brand name drug that comes from Atlanta, I think. And so it should be good quality. I'm sure there's fake drug on the market. You know, that's a big issue in less developed countries. And then you can find people selling, you know, bottles of azithromycin that say, you know, donated by IDI, you know, not to be sold, and so on. So I remember Wandu Alamayu and I went into a pharmacy in Addis Ababa, and, you know, that was what we found. So people are stealing it and so on and then selling it. But anyway, it's you have a lot of issues like this. I think fake drug is a big issue in less developed countries, but this one is mostly being flooded by official drug being sent by ITI. So it's probably not a big issue with that particular situation, although sometimes there are national shortages. Like for half of our trial, there was a shortage. We actually weren't able to replicate the benefit of that from a previous trial in our sort of observational analysis of that.
Okay. Thank you very much.
All right.